Hello and welcome to Radiance Revealed, the podcast. I'm your host, Dr. Jen Haley. I'm a board-certified dermatologist, fitness enthusiast, nutrition expert, and global explorer that over the years has uncovered that your skin is a true representation of your internal health. Each week, we will chat with leading health, wellness, and even spiritual experts who will reveal secrets to true health and vitality. My goal is to help you change small habits to give you the power to create a more balanced, aligned, and elevated version of yourself. Now let's dive in. Hi, everyone. Welcome back to this week's episode of the Radiance Revealed podcast, and I'm your host, Dr. Jen Haley. I've been on a bit of a hiatus lately because I've been recording another podcast called Listen to Your Skin by Moon and Skin. And I've been collaborating with them, so you could check out that podcast for other information. And I will still keep recording on here. This is my second recording of the introduction because I want to apologize in advance for the audio on my end on this episode with Dr. Marc Avram. Dr. Marc Avram, he's so wonderful, and he is the guru in the field of dermatology. Anytime I go to a meeting where all of the dermatologists go, there's a small group of us in the United States. It's a pretty tight-knit group. And he's pretty much the hair expert in the dermatology world. So I had reached out to him. It took us months to get this date on the calendar. And I find that the initial time I record, unedited, it's always so raw and organic. And I think exactly what we want to hear, to have a real conversation, asking real questions with initial answers. So he agreed to re-record with me because my audio was so bad. I have an entire new system. Forgive me, I'm not technical and I don't know how to work it, and my audio is awful. But he's the one who shares all the pearls. So his audio is great, and that's what I hope that you focus on when you listen to this episode. So let me introduce Dr. Marc Avram. He's a board-certified dermatologist and a professor of dermatology at the Weill Cornell Medicine Center. He specializes in comprehensive hair loss solutions for men and women. And he also has a private practice in New York City where he offers medical, surgical, and regenerative treatments, including FUE and FUT hair transplantation, which we do discuss in the podcast. He also offers PRP therapy and high energy in his office and low energy laser treatments for hair restoration. And he's also been an editor for multiple textbooks on cosmetic dermatology and hair transplantation. And as I mentioned, he lectures on topics at many, many, many medical meetings. So who else would I go to besides Dr. Avram? And we talk about all of these things, like what can you do at home before you even see a dermatologist? When should you see a dermatologist? What are the most common causes of hair loss and how do they present? And what are the different ways you can treat it, as well as what you should expect in the treatment regarding timelines? So I hope you enjoy this episode. In future episodes, I'm going to be keeping the episodes to about 20 minutes of pearls on my own. And then when I am lucky enough to have a wonderful guest, I will have longer episodes. But for the most part, I want to add value to your week every single week and give you little pearls that you can integrate into your life to live your best life. Okay, enjoy this episode. And if you like it, it would really benefit me and the podcast if you shared it with a friend and if you rated it. I want all of your feedback. Please reach out to me. The best way is to DM me on Instagram. I'm also becoming more active on Threads, and I'm on LinkedIn quite often. So reach out to me if you have anything that you want to do regarding consultation with Dr. Avram. You can reach out to him as well. Okay, bye. Welcome to the show, Dr. Avram. So happy to have you here discussing hair loss.
It's a pleasure being here. Thanks for having me, Jen. I really look forward to it.
Yeah, very much. So we were talking a little bit offline. I think a lot of people will nowadays throw out the word alopecia. What is alopecia compared to hair loss? And what does this even mean when somebody comes to you in the office?
So alopecia simply means hair loss. So if someone's saying the word alopecia, what they're really saying is hair loss. Sometimes people, I think, make the mistake. They hear the word alopecia and they think they're talking about alopecia areata. And that's a separate condition. But to us dermatologists, alopecia simply means hair loss. And it's extremely common condition. It affects, different studies, say 50% of men to different degrees, and importantly, a significant minority of women as well. So it affects men and women. I'm talking about genetic hair loss, and it really can affect people. It's one of those things that, like, if nothing else, listening to this, if someone has hair loss and they just acknowledge it to someone that you have a problem, that half the time in my experience makes someone feel better, because too often people come see me in the office and they'll say, well, I went to my primary doctor, or my spouse or my friend was like, come on, that's not like, please. Like, and they say, I'm kind of rational. I know it shouldn't bother me so much, but it does bother me so much. So just telling someone that you do have a hair loss problem is part of the way you can help them. And then of course you do an exam, you work it up, and then you decide what to do. So alopecia just means hair loss. It's very common. It affects a lot of men and women.
Right. And, as board certified dermatologists, I don't think people always understand that we don't just specialize in skin. We also specialize in hair and nails and all of those things. And there are so many times, especially in training 20 years ago, when I'd have patients come in and they say, I'm losing hair. And we'd be like, no, your hair's thicker than mine. But isn't it about 30% of your hair has to be lost before anyone would actually notice it?
Yeah, that's the point about acknowledging hair loss. You have to lose 30 to 50% of your hair to begin to notice the hair loss. So if someone comes in, and if you saw them sitting next to you on a plane and they look like a full head of hair and they're telling you they're losing hair. No one's wasting their time to come in and see a dermatologist about a problem that isn't real. It's just the public, all of us kind of are used to seeing hair loss where you notice the hair loss. But yes, so you can lose, that's thousands and thousands of hairs before you begin to even notice it, which is again why it's so important. If you think you're losing your hair, seek treatment. Because first of all, from just a purely practical point of view, if you can identify the reason you're losing hair and then do something medically to stop it, the world will never know you have a hair loss problem. That's a nice thing. And we think most treatments are most effective at earlier stages. Just like you hear about um, everything in the human body, you pick up, fill in the blank, diabetes, cancer, all the things we don't want. And if you pick it up earlier, it's managed better. I think that's true of hair loss too.
Yeah, that's a great point. Okay, I'm going to share something personal. I don't think I've ever shared this with anyone, but that's the kind of person you are. Everybody wants to come to you for their hair loss. So when I was a child, we had a strong family history of hair loss, female pattern hair loss. And we can describe how that first starts, but basically often widening of the part,
Yeah.
literally receding of the hairline. And I was 19 years old in college at Cornell. And I noticed a burn on my scalp. And I looked, gosh, my hair is thinning. My grandmother had wigs. My aunt had wigs. I have these memories of my dog running around the house with my dog, with my grandmother's wig like it was a dead animal. It's just horrible. And, when my brain went there, it gets there all of a sudden.
Sure.
So I've always had an interest in what supplements and using topical minoxidil and things like that. So can you break down when somebody comes in and they're saying that they have hair loss, or if they want to use the word alopecia because they saw it on TikTok, when you now know it's the same thing, it's hair loss. It's not really giving you a diagnosis necessarily. How do you evaluate someone to determine what type of hair loss? And then let's focus on the common type of hair loss today.
Yeah. So if someone comes in, first thing, as any doctor would, you get a history. You say, how long has this been going on for? And in hair, history matters like in everything else in the body and in the skin. And if someone comes in, for example, and said, I had a completely full head of hair, and in the last 3 months, I feel like I've lost half the hair on my scalp, says that, says lost half the hair. You may be thinking one thing. as a dermatologist, a telogen effluvium, a disruption in the hair cycle. If someone says, I've been losing my hair for 10 years, 12 years, very slowly, very gradually, I'm not even sure, but I think when I look at pictures, it's slowly, gradually thinning, you're thinking another thing. So history is the first thing. Second thing, again, we're both taught, all of us dermatologists, look at the skin, right? So we look at the scalp because the scalp is part of the skin and we kind of see the pattern. And that can really break down what might be going on. If someone's skin looks healthy, and as you said, if, for example, in a woman, if her hairline is intact, but it's just less hairs per square inch, let's say, than in the back, you're thinking maybe it's genetic. If you look at a man's scalp and you see some recessions on the sides and thinning maybe in the crown, you're thinking maybe it's male pattern. If you look at the scalp and it's red, it has pus bumps, it has little pimples around the hair follicles, you're thinking maybe this is a skin disease. That's why I think the key thing to see any doctor, but a dermatologist, as you said, we're trained in hair, skin, and nails, right? So a dermatologist, these subtle things in the skin will really take us down one path or the other. So most of the time we can make the diagnosis clinically, meaning through exam and history. However, if there's any doubt, we'll do a biopsy. Just like if you go see a dermatologist and there's a mole they're not sure about or that there's a rash they're not sure about, if you're not sure what's going on the scalp, we take a little sample and we send it out to a dermatopathologist. They'll look at it and they'll give us an answer what they see. So it's really history, examination. And I should say part of the history is not just the hair loss. What's your medical history? Right. So if someone says, I actually have a very active thyroid problem, or I have an active immune problem, or actually I just went on a GPL-1 inhibitor, Ozempic, and I've lost 50 pounds. All these things can impact your hair. So it's not just a hair loss history, it's your general medical history. So you get a general history of everything going on in their scalp and in their body, their medications, their diet, and examination. And if you're still not sure, you do a biopsy. But most of the time between history and examination, you can make a diagnosis.
We're dermatologists, but I really want everyone to understand the point that hair loss is not simple. There are many, many, many different causes. There's entire books written on all the different types of hair loss. And there's scarring types of hair loss, and then there's non-scarring types of hair loss. And I think today we hone in the discussion on non-scarring hair loss. So with the history, like we'll talk about telogen effluvium. A lot of people might have heard that even from social media. But that's the hair loss where your hair might come out quite abruptly in clumps.
Correct.
It's really good. The shower, their hair is coming out in clumps. And this is usually after a period of time after an illness. Can you expand on that a little bit?
Yeah, sure. So telogen effluvium's extremely common. And the thing, sometimes they're very easy to diagnose. The classic one that we learn in residency, for example, or maybe even before residency when we were interns or even medical students, is after giving birth to a baby. It's kind of thing, you're delivering a baby late at night and they're asking you questions and they say, what could happen to this woman's hair? So telogen effluvium is basically a disruption in the hair cycle. All right. So, and it can be anything. It could be a physical stress, delivering a baby, a surgery, the anesthesia from the surgery. So it could be physical. It could be a psychological, emotional stress too. So if someone says, I'm just making up a terrible scenario here, someone I was very close to and I love very much just suddenly died. How long ago? 3 to 6 months ago. So a telogen is usually 3 to 6 months after the event is when it's really at its peak. So if someone says, I had a major surgery, I had a 9-hour surgery on my spine 6 months ago, and my hair's been falling out the last few months, probably related to that. So there's either a physical, emotional, psychological trigger. It can also be triggered by a medication sometimes. For example, as dermatologists, we give a medicine sometimes Accutane, which is a medicine to treat severe acne or recalcitrant acne. That can sometimes trigger a hair loss period. The important thing is, this is the ironic thing about telogen effluvium. If it happens acutely, so if someone gives a history of big loss in a short amount of time, says, I really went from a great head of hair. I was like, had the best head of hair in my, social circle to now I'm like so upset. I'm like, just, it's falling all. So these are if someone says it's like all over my carpet, it's all over my shower, it's like all over, that paradoxically is a sign that you can get it back, that this is disrupted. So I tell people the fact that it's so acute and so horrible is kind of gives me hope that we can make this much better in 6 to 12 months. So an important thing with a telogen, with all hair loss issues, is anything you decide to do to treat it, any therapy you do is measured in months, not days or weeks. So I've seen this unfortunately too often. One of the things that we do in this office is as well hair transplant surgery, regularly. And I get the history, and I've heard so many times that people use the therapy for their medical hair loss, and they gave it 1 or 2 months. They didn't see the results that they were looking for, and they stopped it. I don't dwell on it because why dwell on something that you can't change in the past? But I do make the mental note that we don't know whether or not that's going to work. So if you have a telogen or any kind of hair loss and you see your physician or healthcare provider for treatment, realize in hair, any treatment's going to take 6 to 12 months to really judge efficacy.
Yeah, so sticking with it. Okay, so you mentioned with telogen effluvium, it can happen 6 months after the trigger. And this is often bewildering to people. They're like, that happened so long ago. So I always thought it was 3 to 6 months. What do you normally see?
Yeah, I would say 3 to 6 months, 3 to 6 months. Basically, the way to think of it is your hair has been shut off. So at any given time for you and for me and for anyone watching this or anyone in the world, we have a certain amount of hair growing and a certain amount of hair not growing. That's just normal human hair. So on average, we learn again in residency, you lose about 100 hairs a day on average. So that's normal. You don't notice it. People say, I never noticed this. Well, of course, when you have a full head of hair, no hair, you don't notice a problem until you have the problem, right? What's happening with the telogen, I believe, is that the hair was shut off by whatever triggered it. It's not growing, but the hair loss continues. So you have a instead of, let's say, 80 or 90% growing or 10 or 20% not growing, you might have 50 to 60% growing and 40, 50% not growing. Ergo, you lose 30%, which is thousands and thousands of hairs. That's why you get this history. Again, if you have a history where you just have hairs all over the place, that's almost over the phone. You can diagnose that as a telogen effluvium. Of course, you need to come in and see to make sure, but it's usually about 3 to 6 months after the event.
Yeah, that's good for people to know. So pregnancy, major stress, it makes sense. Even a big surgery or a fever, uh, death, divorce,
COVID, we saw it in
COVID.
when the pandemic was at its peak in 2021. We saw quite a few patients that had COVID that had hair loss a few months later. And what was interesting, it didn't necessarily correlate with the severity of the COVID. You know, some people had terrible COVID and they had a telogen, and other people were like, "Yeah, I thought it was allergies," and they got it. So you get it with that. And now we're seeing it a lot with the weight loss medications, the GPL-1s with the Mounjaro and Ozempic and all the others, they're doing it. And I think what's going on there, I don't think it's the medication directly causing the hair loss. I think it's the big change in the amount of nutrition that you're taking in. So I don't, this is my theory, but I think that's what's happening. If your body suddenly has our body likes steady states. We like things stable. So if I'm used to a certain amount of energy going into my body, and all of a sudden that's changed because my appetite is reduced and I'm taking in less energy, meaning food, one of the things the body's going to say is, I need to do more. I have to be more efficient, basically. I don't need the hair right now. Right? So you're going to go into a telogen from it. So we're seeing that with it. And so what I tell people, of course, if you're using it, one of these to lose weight, and that's a good thing on many levels, just consult with your doctor about nutrition. because the one thing you can control is make sure if you're not eating the same, that at least you're taking some supplements, some vitamins that you cover what your body needs with it. That might help reduce the risk.
So do you think it's calories or do you think it's the nutritional building blocks that are being mixed? Or we're not really sure at this point. Yeah, a little bit of
It
both.
could be both. It could be the nutritional building block, could be either one.
So, I mean, I always recommend if someone is on one of these medications to make sure you focus on nutrient density, right? Like avoid crackers and bread and things like
Yes.
that because they tend to be kind of nauseous on the medications. So they aim towards those things rather than the high density nutritious foods. And that's neat. I'd love to see a study on how we navigate. Like what's the special formula where people can lose the most amount of weight and still stay as healthy as possible and not lose their
And
hair, right?
and the thing that makes the human body so mysterious is that one person can have a problem with it and the next person not at all, right?
Right.
So this is not across the board, but what you said to me just now makes a lot of sense. Make your nutrition what you eat. Yeah, don't eat empty calories, right? Eat nutritious food. I think that's probably a good thing to do in general in life, but certainly if you're in a weight loss journey, to think about that too, for sure.
I always think about it from an evolutionary standpoint, like if we are in a stress mode in any capacity, our body takes away all of the things that we would do to procreate. So why do we need glowing hair or, why do we need beautiful skin? I mean, we don't need those things and we don't need fertility. And that's why women who lose too much weight will lose their period because that's
Yeah.
not a priority when stress is so heavy that it, you know, the higher powers don't want us to procreate from an evolutionary standpoint. So
That's very interesting, and I think you're 100% right. It's true. You lose when yes, and it's the human body. It's basically it knows again through evolution what it's basically. If you think about it, it's just focusing on the core, and it's saying I need to focus on the core and things I can let go temporarily and still survive because I think any organism, anything alive it just innately wants to be alive, right? And so if things are shutting down, it's going to say, I don't need the hair right now. I don't need a menstrual cycle right now, temporarily. And that's what we see with hair. So when you see with it, it's upsetting, but you just reassure the patient. Then we go through things that we can do to maybe stimulate the hair back in a little quicker.
let's jump into that. So if someone has telogen effluvium, either from an illness or from any of the causes that you mentioned, which I thought were pretty thorough, if somebody has that, where do they start with the board certified dermatologist?
So yeah, so what I would say is just if you haven't been to your doctor, just go get a routine physical and blood tests, right? So you want to make sure that there's nothing medical going on. The number one medical reason would be thyroid disorder. Make sure the thyroid is normal, so you get blood tests for that. Make sure there is an iron deficiency anemia. Iron deficiency has been reported with hair loss. It's anything acute. So get a physical. But let's say someone comes in and says, I've had a physical, I'm in good health, everything is good. My menstrual cycle, that's another thing, hormone balance. My menstrual cycle is regular. I just have this tremendous hair loss. Then we're going to directly go after the follicles. And then we go through the options of what you can do to stimulate hair. And I find there's different groups of patients. And I tell them all the following can work and do what you're comfortable with. So, for example, many of the things that we might use to treat genetic thinning, such as minoxidil, topical oral, if it's a man, we wouldn't give it to a woman in childbearing years, but in a man, finasteride topical oral as options. And then there's a lot of patients that say, I don't want any medication or chemicals. Now we have good options, low level light laser therapy, high energy lasers approved last year. There's high energy lasers, and there's PRP as well. So we go through those treatments. And what I tell patients is this: these are meant to just push your hairs down the road quicker than they would doing nothing. So we're taught, and I believe this is true, if you do nothing, most of this will come back. So one option is reassurance, you're going to be okay, hang in there. But a lot of people want to do something to push the hair in the right direction. I think just to say, when you're in this position to do nothing, I would want to do something too, right? So people people pick one of these or combinations, and then this is what's different than treating genetic. I say we're going to see each other again in 6, 9 months, months after the treatments, if we think the hair is better. So if you come in and you say, "Hey, Dr. Adam, high five, my hair's back," right? It's like I'm the way I was before I lost this in this telogen. I'm going to tell you we're going to stop the treatment. We're not going to continue we're not going to continue the laser, the PRP, we're going to stop. And if you stop and then don't lose any hair in the next 6 months, it was pure telogen disruption, and you're good to go. You're done. You stimulated back and you're done. However, if someone loses a lot of hair, you get them back and then stop, and then 3 months later they call you up and say, my hair was really good, but I feel like it's sliding a little bit. Then you had a component of genetic thinning too, a component of female or male pattern hair loss. And then we would stay on the treatments longer term.
I think that's an important point. We don't limit ourselves to just one diagnosis. Sometimes we could have multiple things going on, so it's not always as clear cut as we may think. Okay, so let's talk about the lasers. So at home
Yes,
devices in the office, what do you like? What do you recommend?
I think they both work. They're great. So we know what they are and what they're not. I know you're in Arizona, a very sunny place, a lot of sun, and people are concerned about skin cancer and aging, and so we're used to like light can be bad, right? Ultraviolet light. These devices are safe. So a lot of the at-home devices approved by the FDA are red light in the red light range. Red light as red light is used for skin rejuvenation as well. So first thing I tell people is it's safe and it's painless as well. So how do we decide whether to do in the office or at home? So it's really in the end, I think, Jen, it's personality and lifestyle. So if someone comes in and says, I travel twice a week, I'm like all over the country, I want those jobs that like I'm in banking and I've got meetings, I can't bring that device with me. I can't bring it on the plane all the time. Or I'm going to forget. I'm just the kind of person who's going to forget. It's a waste of money to buy one of these things if you're not going to use it. On the other hand, the next patient who walks in might say, wait a second, I can buy this device, do it at home 3 times a week. It's painless when I do it and it's safe. Why wouldn't I do it? And I say, why wouldn't you do it? Use it. So the low level light is for people that can do it at home easily. If someone says, I really want to do something natural, those are the people that come in the office and do it. They'll come in because the in office, the protocol is you come in once a month for 3 or 4 months. The idea being that the light of the laser creates a little wound, a micro wound in the skin, and that wound healing sends cytokines that stimulate the hair follicles. And then if it works, if we look at images and we see positive results, then we do maintenance about every 6 to 9 months to keep it stimulated. So both can work. And I think which one you choose is more based on your lifestyle and personality.
Okay, so I've had one. Do you have certain brands you recommend? Can you recommend certain brands, or you stay agnostic with that? Because there's so
No,
many.
no. I think I'll mention a few. I've no problem. I've no financial connection to anything. So the one that we often recommend is something called laser cap. Why do I recommend it? Because the cap, they seem to have very good customer service. So if there's a problem with it, you can call them, and because anything that we recommend as physicians, it kind of reflects on us a little bit, right? So if you recommend something and patients come back to you and say the customer service was terrible, I had a problem, they wouldn't get back to me, even though people know you're not connected to them directly, it's still not good, right? So I try to recommend things that work and that have good customer service. But I think there's many good ones. The ones with there's like a helmet that's good. You can Google on Amazon, on Amazon you can put in low level light, and there's a big price range. Okay, so I think the advantage of a cap or a helmet is you don't. It's just easier to put something on your head and turn it on for 30 minutes. You can use a comb. They can work. There's no question they can work. they're cheaper. That doesn't mean it's not going to work, but it's harder to move a comb through your hair over 20 minutes. It's just harder for most of us to do that, right? So it's hard to be compliant. But if someone came in and said, I'm using a band or a comb and I find no problem, I'd say go with that, do it. So I think the price range in these are from the hundreds of dollars to the low thousands of dollars. However, if it works, first of all, it's a good investment and they tend to continue working for many years. So if you just get in the habit, if it works and you wear the cap, you can use it for 10 years. And if you amortize that over a decade, that's not so expensive to keep your hair in a very safe way. So most of our patients end up using some kind of hat is what they use.
Okay, okay. So are there, I mean, I just kind of wonder with the way the internet is nowadays, somebody can go on Amazon and most companies have reputable, or there's certain things that they should look for to know that it's not a knockoff or not going to provide the efficacy that we think it's going to.
Yeah, I think that these devices, the low level devices, are direct to consumer. That's how the FDA approved them a decade ago. So the answer is yes, you can go on there. I think kind of like the way you would with anything you're going to buy, reputation, advice of your doctor, like me, recommending. Um, I think you want to have a high number of LEDs in the cap or whatever device you're buying, and a company that has good reviews for customer service. Most of them are pretty reliable. I think that's the best way. But my advice is anywhere you are in the country, or if anyone's listening overseas, I would ask your dermatologist which ones they've had the best experience with. The higher energy lasers, because they're high energy, are done only in a medical center setting. So that would only be in your dermatologist's office that would be done. Good question. Um, that's a question that comes up a lot. People are motivated. They're like, if they say use it 3 times, if I use it every day, is that going to hurt? So the answer I give is the answer I ask the people who develop these, right? The basic scientists. They say this is the study that we came up with, and this is where we got the optimal results. So I don't, in the sense, is it dangerous to do it too much? Like you're going to cause cancer? No, you're not going to do that. However, kind of like, as a dermatologist, if you put a topical steroid on 6 times a day instead of twice a day, it's not going to work any better. And maybe it may make things worse because you get irritation from it. So I kind of tell people to follow the protocol that's recommended. Um, so I think theoretically it's possible overdoing it could be a negative, but not in the sense of cancer or anything like that, but it may not be optimal. I would go by but where the studies were done.
Yeah, I agree. I mean, we live in a culture where people think more is better often, or
Yes.
more a bit more. And I know with red light devices in particular, and I'm sure you get hit up by all these big mass companies all the time. I can't really endorse any of them in particular because there's so many variables I'm not clear on. But we do know that there's a biphasic response where too little, you're not going to stimulate the mitochondria enough, and too much, you cause too much reactive oxygen species for mitochondrial health. So I kind of wonder the same with hair, like I just want people to know that more is not better.
I think it's the same thing. That's why I tell people follow the protocol. That's the best way to go.
Okay, so they're doing for telogen effluvium. Okay, Dr. Abram, I'll do my low level light therapy. What else do you want me to do? I'll do everything you say to get a response, even if it's a month quicker. What?
So if someone's doing laser, I tell them that alone could be an effective treatment. However, often we'll combine it with something else. So again, it depends on what the patient, because a very common thing is you're the doctor, tell me. I'm here. You tell me what to do and I'll do it. And I just was with a patient a little while ago and I said to them, well, would you be okay if I told you take minoxidil every day, take a pill? I really don't want to take a pill. Well, there you go. Right. So I'm a huge believer in doing a combination that you will do because one of the big areas of failure is non-compliance because the person really doesn't want to do it. So if someone wants to say all natural, say, which is common, says that like something regenerative and not chemical, probably the other thing we would add is PRP, platelet-rich plasma would be the other thing. We would do the cap and then do a series of PRP treatments as well. Um, Usually I won't go beyond 2 treatments at once, sort of. And if people say, "Why not? I'll do everything. I'm highly motivated." Say, first of all, it's not good medicine. We wouldn't treat your acne with oral antibiotics, benzoyl peroxide, retinoids. It's just too much could actually hurt you. And if it works, did you need all these for it to work or not? So we would use the low level light alone or add one other thing. And often it's PRP because people like the idea of regenerative and natural. That's usually what we would do.
Mm, So, can you just explain to everyone what PRP is? Most people understand, but just explain what it is.
So to put in perspective, platelet-rich plasma, PRP, is something done in many areas of medicine, right? So probably where if you're a sports fan, you're going to hear it. Athletes have it. Elite athletes will have injections of PRPs into joints to help healing more quickly. So it's done in orthopedics, it's done in dentistry, in many areas of medicine, including dermatology. A lot of my colleagues will use it for facial rejuvenation as part of post-Fraxel or microneedling. I do it 100% for hair stimulation. So what PRP is you come in, it's a blood draw. So, and we take that tube of blood and we put it in a centrifuge and we spin it thousands of times a minute for 10 minutes. We separate out the clear part of the blood, platelet-rich plasma, from the red blood cells. So if you take the tube out after spinning, you'll see red blood cells at the bottom. We're not interested. Then you'll see it looks yellow. And it's really the lower part of the yellow. It's the most golden, the darkest yellow. That's platelet-rich plasma. We pull that up. And why are we doing this? There's something in those cells that sends signals when you concentrate in the follicles that can tell hair follicles to grow longer and thicker and wake up even some follicles that aren't growing. So I think the trade-off, so what's positive? It's very natural. It's your own blood product. So that makes it very safe. I think the practical thing is it's painful when you inject it in on people. When people are having it done, they're like, this hurts. Not enough to numb their whole scalp like a transplant. We usually use vibrations, and we're cooler. We use squeezy balls, um, and people get through it fine. But that's what PRP is. And I find in some people there's a range of efficacy. I tell people 1 out of 3 people in studies, and certainly my clinical experience, it doesn't work. So I say 1 out of 3 is pretty high, right? Like that's most. If I said 1 out of 3 chance I'm going to get on a plane to fly to Chicago, I'm not getting on that plane. But 2 out of 3 it will work, and it can work anything from maintenance to a little thicker, and in some patients it can make quite dramatic thickening. It almost looks like a post hair transplant. So I think a lot of people are willing to do that, take those odds. And if it works, then you'll do a maintenance once a year if it's genetic thinning. So platelet-rich plasma, the big appeal is it's totally natural. It's your own blood product. Other than the pain, very safe thing to do.
Okay. Let's jump into genetic thinning. So, as opposed to hair falling out response, you mentioned that presents more as gradual hair.
Hmm.
So,
Yeah. So genetic is almost by definition like a leaky faucet. So genetic is happening very slowly. Um, it's something that, in men, the classic, I'm even the classic, and again, we know in dermatology there's always different patterns within, but the classic of a man is a receding hairline on the temples and then in the crown, and then it can um, thin all up on top. And as we know, you can lose it all on top. So, and I tell people there's a huge variation. There's some men that literally in high school have a head of hair, and by the time they're done with college at 22, 23, they're bald or close to bald. It can happen quickly, or it can happen slowly over decades and never go bald, right? And we know many men like that too. Their hairline just gets a little higher, but they always maintain the hair and never get bald. But it's always progressive. So that's male pattern hair loss. Female pattern hair loss, very important. Again, for any woman with hair loss wondering what's going on, one of the key things is a woman's hairline remains intact. So the hairline is intact. It just becomes more, it just becomes more and more see-through, right? So the chief complaint is it's becoming see-through. And what you just showed me, Jen, your hair part in the middle becomes wider, right? So you're like, I feel like a Christmas tree almost. It's like thinner in the front and the tree's just getting thinner and wider up top there. And it happens slowly. And so a chief complaint is I got to put a lot of hairspray on. I got to put like topic in, like a something to camouflage, hairspray to camouflage what's going on. So that's genetic. Now, big question is why do I have this? Now I keep saying genetic, but we don't understand the genetics of it, right? So this is an important thing. We do not know the genetics. So do not look, if you're younger and listening to this, do not look at your mother or father and think that's exactly what's going to happen to me. It does not fit that way. Certain things in the human body, for example, eye color, I think is mathematical. You can predict that. Genetics is very predictive. With hair loss, we don't know the genetics. We think it's multiple genes together that causes that in 2025 we still don't know what they are. It's not known what it is. Um, so I think a fair thing to say is if you have a strong family history of hair loss, like if your uncles on both sides and everyone's got thin hair, you're more likely going to get it, but not necessarily. And to give an illustration, you can have three brothers or three sisters, one with a full head of hair, one with some thinning, and one completely bald and very see-through. Same parents. So so do not necessarily look at your immediate relatives and think that's where I'm going to be going. And I think another key thing is we can do something about this. We can
So, are there any epigenetic variables that we know about that can turn on the genes for hair loss?
Great question. I don't think so. I I don't think so. I don't think anything is ever correlated in terms of what a trigger could be, because everything you wonder what could be that doesn't hold up statistically.
Right?
So
Yeah, that's the thing about dermatology is there's so many, there's over what, 3,000 diagnoses in dermatology. And we don't know the cause of a lot of them, but we do have good treatment, to your point. So,
correct. And
so
to show like where telogen, what we spoke about earlier, medical status, nutrition is so important. In male and female pattern hair loss, of course, nutrition is important in everything in the body, including your hair. So, like to your point, if you're extreme loss, you're gonna thin all over. But for in classic male pattern for men at least, men retain thick hair in the back of their scalp and they thin up top. If you were truly nutritionally deprived, if it was nutritional, you would thin all over. So if a man comes in there kind of thinning all over, I'm going way down that road of nutrition, medical, something is going on. But if someone has really thick hair in the back of their scalp and thinning on top, why would the body only thin up top? That's a genetic trigger.
yeah.
And same for women, so um we don't know what the triggers are. I'm sure once we know it will be obvious to us, but we don't know. Nothing correlates.
Okay, so how do you go down the treatment algorithm for both men and women?
So again, make the diagnosis, do the exam, and tell people, I usually tell people at the beginning, I say, we can treat this. We have good options. I emphasize the length of time because all of us, myself included, are used to a certain time frame to see results and quick, right? And I'm saying it, I explain why it's slower in hair because the biology of the hair is slower, so that anything you do, we and I say probably a few times in the consult, we're going to give it minimum of 6 months, really more like 8 or 9 months to judge it. And then I go through the options. Things that I think have either FDA approval or good clinical up the middle dermatologic literature support to give this to a patient. So that would be, again, topical minoxidil, oral minoxidil now. 10 years ago, not, but now oral minoxidil, I think, is very standard. Topical oral finasteride for men only. because if a woman takes finasteride and gets pregnant, it does cause birth defects in a male child. So we would not give it to a woman in childbearing years. And we would talk about laser in office, low level laser therapy, and PRP. And then which one to choose really depends on on someone's comfort level, right? And so if someone says, I want something with the least potential side effects, I want something safe, I tell them there's no such thing as something that has no risk. Everything has a risk, but you're asking me what has the least risk, right? With it, probably topical minoxidil is pretty safe. It's the FDA says it's safe to the point where it's over the counter, and probably the laser cap would be in those categories of things that are effective. And you could combine the two. If you do topical minoxidil, so let's say you have male or female pattern hair loss, the laser safe. Topical minoxidil, 98% of people have no side effects. Sometimes in women, it can grow hair where you don't want it. Like it can activate hairs, um, which is reversible. Some people you can get dizziness. Some people you can get palpitations, but most people do well with it. And again, you go down the algorithm of what you think the person's going to be compliant with. I'll give you a couple of examples. Not uncommonly, not uncommonly, I'm talking about a man will come in and say, I'm here. I want my hair. I want to do everything I can, but I don't want to talk about finasteride. I don't want to talk because I read about that can affect my sex drive. And I'm not even going down that road. So please don't even bring it up. I don't want to hear about it. Right. Next person will walk in and say, my cousin's been on finasteride. My father's been on finasteride. It's worked fantastically for them. I've read about the side effects. I realize that's 2 or 3% of people reversible. Um, I want finasteride. The point being, tune in to what the person's willing to do.
Exactly. It's sort of like Accutane too. They sort of say that. So what about injectable finasteride? Do you ever do that?
Injectable,
Finasteride.
I haven't, but there's no reason you couldn't. And I would probably there's a first cousin of finasteride, dutasteride, why would I inject that if I was going to do it? Because that has a much longer half-life. It's for weeks. So it's called mesotherapy. Again, if you look online, this is going to come up. And why would somebody do mesotherapy? Well, I guess you would do mesotherapy again if you're not compliant with taking it every day, the pill, but you like maybe the idea of what a finasteride or dutasteride can do. And what you do basically is you inject, kind of like PRP, you inject it into the scalp where the follicles are, and you would do it every couple of months because the half-life is so long. I think finasteride is not long enough to do it. You'd have to do it too often with it. So if you're going to do mesotherapy, I think most people are doing it with dutasteride. I just haven't done it because most people, I find, if they're willing to take, I think the big hurdle to finasteride and dutasteride is getting over the potential sexual side effect and the post-finasteride syndrome. If someone's comfortable with that, they'll take it orally. It's not a problem. But if someone wanted to do it, that's definitely an option. There's been some studies in the dermatologic journals recently that support it, and I have colleagues doing it. So I think it's an option to do it that as well.
And then with the topical minoxidil, you just jump to the 5% foam for women as well and do it once a day.
Yes, all men and women, 5% foam. Patients always say, well, there's different labeling. That's purely marketing, how it's labeled, but it's the exact same medicine. And we go exactly to 5% for both men and women right off the bat.
Yeah. But typically with the liquid, I don't know if it still has propylene glycol, but I saw so many reactions with that early on. So we always just went straight to the foam.
Correct. And I would say that to most people listening to this, if you're going to do the top, I would go straight to the foam for that very reason. So propylene glycol is a chemical in the liquid form of minoxidil. And I agree. We used to see a lot of irritation from it. A lot of people would call up and they weren't. And what we would end up doing is going to pharmacies in New York and asking them to make a propylene glycol free solution of minoxidil, which is more expensive. And that worked, but then they came out with the foam, which is propylene glycol free, and reactions to that is rare. So that's why for most people we recommend the foam.
Yeah, so the 5% once a day for women and then twice a day for men.
Yes. And another little point that might be helpful. If you look at the box, if you order it online or go into a pharmacy and pick it up, it only talks about in men the back of the scalp. If you look at the cartoon insert, it only talks about the crown. That is regulatory. And I make this point to every patient, put it in the front and back. Because if you just look at the labeling, you're going to say, okay, I'll just put it in the back because that's where they tell me to do it. And I say the FDA is very stringent about regulatory, and you can only comment where the study was done. And most hair loss studies are done in the crown and the vertex. That's why it says that. However, we have good clinical trials that shows it works just as well in the frontal hairline. So I tell people once a day over the whole top of the scalp. And the other thing is the box will say twice a day. So you might get a phone call or an email of somebody saying, you said once a day, it says twice a day. I think it's because compliance is much higher with once a day. And the studies that we've done in the field have shown that it works as well once a day as twice a day. That's why we suggest it once a day.
Top of third, because that's really what people are doing anyway.
Yes. I think it's so much easier to do it once a day. You do it at night before you go to sleep. You wake up, you take your shower. It's no issue.
Exactly. Okay, so let's talk about hair transplantation. I know nothing about it. I always have to send people to specialists like you because it's so highly specialized. And how do people, at what point do they need hair transplantation? How do you prepare the skin for hair transplantation? What are the different procedures that they can do? What is the aftercare expectations? All of it.
So, great question. So, a hair transplant is a dermatologic surgery. So, I tell people it's a skin surgery, it's local anesthesia. So, you're awake during the procedure. And what it's based on is the fact, as I said earlier, for reasons unknown in medicine or any area of study, if you talk to anthropologists or no one really, it's a very quirky thing of nature. Why do we thin up here, but we don't really thin in the back? No one knows. But that's what a hair transplant's taking advantage of. You're basically taking your own hair from your own skin and you're just doing a zero sum. You're rearranging it from the back to the front. Couple of important things. In the 1960s into the 90s, dermatologists would do what was called plugs. So anyone who had it then is now, I'd say, middle to older, right? So the first thing is that is completely gone. I think most of us probably know someone who's had a hair transplant and they don't know. The point being, it's so natural now, you shouldn't even know it was done. Because what we do now is we take individual hair follicles from the back and we put it in individually. So there's two methods. I'm just giving an overview. There's something called FUE, which is an acronym for follicular unit extraction. What that is you come in, we have to trim the back of your scalp as short as my beard is now. We basically buzz you to a zero in the back. So what does that say? Nearly 0% of women are going to do FUE, right? Like if I said to you, Jen, I'm going to trim your hair, you'd be like, you'd say, get away, right? And it's not necessary. But a man who wears their hair shorter, it's not such a big deal. The hair is going to grow back in a couple of weeks. The advantage of FUE is the biggest incision in the procedure is 1 millimeter. And what we're doing is we're taking 1 millimeter punches and we're removing hundreds and hundreds and hundreds of these follicular units from the back of the scalp. You basically put moisturizing cream afterwards, Aquaphor, and these incisions heal in about 5 to 6 days. So what's the big appeal for that harvesting technique is not single stitch, and the scars are so small that if you decide to buzz your hair at some point, like you look like, you're joining the Marines or something, you're buzzing your hair short, there'll be there'll be scars, but the eye won't really pick up on it very much. So that's very appealing. The other technique for harvesting is it's called FUT, follicular unit transplant. It's basically an excision. You lift up the hair. So, for example, earlier today, we did a transplant in a woman and her hair was about your length.
You
Why
just
would
looked
we?
at for those on
So,
YouTube.
so we just lift up an area in the middle, let's say the top of your ear, right in the middle there, and we separate the hair and we basically lift the hair up and we put clips in and then we trim an area about half an inch wide. You lay in the prone position, meaning on your stomach. We numb it with lidocaine, local anesthesia. Then we remove the hair. It's an excision. So we do an excision of hair.
Like
So
how wide? How long? So it's how
we
wide?
don't we don't want tension on the wound. We want a very fine scar. So usually we will not go wider than 1 centimeter wide. So zero point 0.8 centimeter, and how we get our numbers length. So we might take a strip 10, 12, 14, 16, 18 centimeters long, ear to ear, to try to get high numbers of follicular units. Then you close it with the stitches. The typical scar is like a pen line. So a typical scar from that technique, even if you wore your hair my length, you're never going to see that scar. The only way you'll ever see that scar is if you shave your hair off, right? So in a woman, what's appealing, and for frankly a lot of men, is the hair that we lifted up covers the stitches the next day. So if you're walking around in New York or Arizona or anywhere in the world, nobody will even know you have the stitches the next day. Um, and no one will ever see the scar. So why would someone pick one or the other? If someone might want to wear their hair short and they don't want a line, if they buzz their hair off, I do FUE. If someone's like, I'm never buzzing my hair off, most women and some men, why trim your whole back of your scalp? FUT. And then when we get that ellipsa hair, we, meaning the staff, it's so one thing about hair transplants, it's a multi-person procedure. It's not something that I alone could do, right? So if you were in my office, it's myself and probably four or five other people in the room, and we're dividing under magnification all these hairs from the tissue into follicular units. And then it's the same, whether you do FUE or FUT, it's the same. You do the follicular units, you numb it. So, for example, in a woman, let's say a woman is thinning and she says, I don't like, I can see through my hairline.
Here, the part would have.
Yeah. We'll numb it with local and then with magnification, make a little nick, like the equivalent of a 20 gauge needle, let's say. And we make, hundreds and hundreds and hundreds and hundreds, 1,000, 12, like a lot of these little incisions. And then we put the hairs in one at a time. We just, and it, so you can imagine even a highly efficient team, this takes a few hours to do. Then you go home. Usually there's not a lot of pain post-surgical. Usually people can like be on the computer, walk around right away. I think the biggest impact practical is we tell people not to work out for a week. So if you're used to working out every day, and that's a lot of people that we see, like they like working out. We just tell them walk 5 miles a day, but do not run 5 miles a day. Do light 5 pound weights. Do not do bench pressing because we want the back. We don't want sweating. We don't want to get a folliculitis or any kind of breakouts from it.
Probably.
Yeah, we just want it to heal. For 1 week, just no heavy sports. And then after a week, you go back to your routine. And then, like everything I've been saying in this podcast, you don't see any results right away. The transplant doesn't grow for the first 3 months and it begins to thicken over 6, 12, 15 months after the procedure. So who doesn't do a transplant? A transplant is for restoring hair in an area that you can't get back medically, is what I would say, right? So if let's say you stabilize through one of the medical therapies that we talked about, and someone says, I'm happy about that. However, my hairline is still receded so far back. I want a little bit more of a frame. I think a transplant's the only thing that's going to really do that, right? Same with a woman. It's stabilized medically, but I want to wear my hair back wet in the summer and not be self-conscious. A transplant's really going to do that. So that's the candidate. I think what's the challenges of transplants? Like, what's the challenge? I would say, first of all, it does not fix the problem. What do I mean by that? You just said it adds hair back. Usually when you use the word surgery, you're thinking about solving an issue, right? So if you have someone in your office has a skin cancer on their arm and you cut it out, you've gotten rid of that cancer. That cancer is done. A transplant does literally 0% to prevent the ongoing male and female pattern hair loss. So you can imagine the scenario that's quite often someone comes in their 20s or 30s and they're thinning and they're like, just put the hair back. Just fix the problem, doctor. just put my hair back. And you're like, well, we can put hair back and we can add hair, but if you don't do something medically, you're going to be ultimately trading hairs. So the way you get that look, and this is what you see on social media of someone with the really full restoration, is usually successful medical therapy and surgery. If you do just surgery and you keep losing, which some people opt to do, you might have to come back and do it again to reinforce as you keep thinning. So, so transplantation is again, from a medical point of view, as a doctor, very low medical surgical complication rate because the blood supply up there is so good. Infection, things like that is very rare in a transplant. The success rate is high. It's not 100%, but it's 90% plus. So it's a great procedure for what it does. You just have to pick the right patient. You have to have enough donor density, enough loss that you can do it. And as with anything you do in your office, the right expectation of what it can do and not do for the person.
And patience.
Yes, you need to. So if someone, for example, let's say someone like me came in, right? And my hair is kind of fine and I brought in a picture of like Brad Pitt, and I was like, I need this hairline. You have to say, you don't have that kind of hair. You don't have the density in the back. What we can do is prevent you from being bald. We can make it look natural. We can give you a head of hair up there. That's a huge cosmetic difference. But if your expectation is a completely full wavy set of hair, the reason we can't do that is because you don't have that kind of hair. If someone comes in and they have very dense hair, thick hair, wavy hair, you can make a pretty dramatic before and after, for someone. So a lot of it is what you have, right? You can't change the kind of hair you have on your scalp. And you just explain it to people. And I find most people, if you explain it, they kind of get it.
Yeah.
So,
Yeah, it's like building a house. You can't just use a hammer. You have to use all the tools in the toolbox and to get the best results. So that's
yes,
really good.
yes.
Okay, can I pivot while I still have you as we close out here? Gray hair. Do we have any good treatments for gray hair besides hair dye?
That is one of the holy grail. There's many holy grails for hair. For me, one would be some kind of genetic test to tell somebody where their hair loss is going. I think emotionally and psychologically, just knowing where you would go would just make it easier. Whatever it is, that would be one thing. Two would be cloning hair, right? If you could clone hair, you would have a limitless donor area to transplant. So in transplants, we can do a couple of surgeries, but the reason sometimes we can't get it to there's only so much you can get from there in the end. So that's the one thing. And the third would be hair color, right? If there was a way that you could say, I want to go blonde the next 6 months, or I want to go like full brunette without dying, doesn't exist. Don't have it. We're still in a world where the way you change color is through dye. We don't have anything medical. We have no laser, no pill, no supplement that really can change and prevent gray hair. We think it's genetic. We keep saying that because most things in the body are. And to date, nothing to reverse it.
Is it the cellular synthesis as the of the pigmentation of the pigment in the hair bowl?
Yeah. So what's happening with turning gray, your hair, that's a good point. It has nothing to do with your hair health, right?
Hmm.
So the two happen to happen, they can happen simultaneously because you can have genetic thinning as you become an adult, and that's when you get gray. So people can falsely make the conclusion that, oh, I'm getting gray and that's why I'm losing my hair. That's not correct. They're just two independent things happening. What's happening is when our hair grows, we usually have a transfer from the melanocytes of melanosomes into our hair for our hair color. And that transfer stops, is what happens. So you can have a completely full head of hair, full healthy head of hair, and be completely gray, right? And you can be completely bald and have not a single gray hair on your head, right? So the two things are independent. And what's happening with gray hair is you're losing the transfer of pigment.
Interesting because we'll hear these cases sometimes where people repigmented and we just don't really understand. And I know there's people out there in the biohacking world that are saying, oh, this works and it repigments. And I'm like, if I don't understand the mechanisms and back then, and I can't
see a study on it, I'm not going to believe it, so that's why I'm asking you.
Well, we've seen it. You can see, like, for example, as sometimes with like alopecia areata or certain scalp conditions, when you get the hair to grow, the first cycle is gray, right?
Right.
So sometimes people go, Dr. Avram, I'm happy my hair's growing, but I'm like 23, my hair's gray that's coming in. I'm like, just hold on. It
Wait.
will just waiting will keep cycling, the pigment will pick up. So there is something about growing hair and lagging. But in terms of someone comes in and says, I'm dyeing my hair, well, what can you do to prevent me from dyeing my hair? And I don't want to see gray hair. I can't offer anything that I can look them in the eye and say has a chance of working.
I know. I'm curious. I always think like how if we think the cause is senescence and we can clear out some senescent cells through what a top, fasting or whatever, or so many supplements like lecithin. Would that help with the gray hair? I mean, these are things that are to be determined, but at this point, we really don't have anything besides.
Yeah, and this is an area, as you can imagine, of great interest in gigantic pharmaceutical companies. I know that people are definitely working on it. It's not lack of interest. And again, as it should be, this is being done in private sector, biotech, and in like L'Oreal type companies, big companies to come up with it. They have scientists trying to figure it out. I don't think anyone has done it. This is not, and nor should it be, NIH funded type sort of stuff. This is all private industry, but there is a lot of interest. And when people say, well, if we haven't done, why are you so sure it's going to happen? Like, I think, I don't know when, but I think we will clone hair. I think we will be able to change color without using a dye. Why? Because the progress of biotechnology, computer power, the knowledge of genes is accelerating so rapidly. We will figure these things out. But right now in 2025, we don't have it.
Yeah, I agree. I think it will come, it's just a matter of when. So, well, thank you so much. Was there anything I didn't ask you that you think is pressing that you want to share with everyone?
No, I think that the main thing is, again, thank you for having me. I enjoyed speaking with you. And I would tell anyone with hair loss, if you think you have a hair loss issue, go see your dermatologist and let them examine the scalp. And I think the other big thing is, in not all cases, sometimes we can help someone, but most of the time we can really impact it in a positive way. So don't some people still have this idea, I'm losing my hair, it's just part of life, I just have to live with it. I would say, if you want to, go ahead. If it doesn't bother you, let it go. That's okay. But if it bothers you, go see your dermatologist, and I bet you they can do something to turn it in a positive direction.
And you're based in New York. Do you do any telemedicine?
I do. I do. I'm in New York and I do that. Yes, I do. I do it mostly in the office, but I have patients all around. So we talk like this, sometimes to people that are that are a little further away.
Okay, great. Okay, so are there any social channels people can find you on? And I'll have everything in the show notes as well.
No, I would just say my name is there. I see my name on there. I think just, Google it and see my website, dravram.com. I'd say it's probably the quickest way. My name, drabram.com is probably the most direct way.
Thank you so much. I really appreciate you.
You're welcome, Jen. Have a nice afternoon.
If you're enjoying the Radiance Revealed podcast, please don't forget to subscribe so you'll always know when there's a new episode. And while you're at it, please give us a review, as that helps others to find this podcast. And if you want to connect with me, please visit my website, drjenhaley.com, or you can find me on Instagram at drjenhaley.
Hello, everyone. Just a friendly reminder that this podcast is for educational and informational purposes only. The statements and views expressed on this podcast are not medical advice. Opinions of guests are their own, and this podcast does not endorse or accept responsibility made for statements made by guests. Neither this podcast nor any of the information contained within it are a substitute for care by a qualified medical professional. This podcast is provided with the understanding that it does not constitute medical or professional advice or services. If you are looking for help in your journey, please seek out a qualified medical practitioner.